happens when the potential harms of a medical experiment are not conveyed to its subjects? Is there a social moral responsibility to provide healthcare to all? And what does it mean to die with dignity? What are the conflicting social values and personal beliefs around such a practice? My name is Melissa Karen. I'm the director of the Mudd Center for Ethics at Washington and Lee University, and these are some of the questions we will think through together during our year-long program entitled How We Live and Die: Stories, Values, and Communities. The program, full of lectures, a panel discussion, and a multimedia art exhibition, effectively combines the scope and depth of both the humanities and sciences to address the most pressing issues of medical ethics today. So what is this field of medical ethics? There are four main pillars of medical ethics, and these are generally autonomy, giving the patient agency and information to choose freely; beneficence, doing good; non-maleficence, committing to non-harm; and justice, ensuring equity and fairness in care. The premise for this four-principled oath is based, in part, on the Hippocratic Oath, named after Hippocrates, the Greek physician of the 5th through 4th centuries BCE, who may have been the original author of the oath that outlines moral behavior and expectations of a physician. While the current bioethics or medical ethics principles just outlined are informed by ancient Greek medical ideals, it may be surprising to learn that they are in fact only recent formulations, as recent as the 1970s, by philosophers Beauchamp and Childress. It's also helpful to remember that ideas and concepts of medical ethics are not the sole domain of Western culture. Ancient Chinese and Indian, as well as medieval Ottoman cultures, all produced treatises and pledges related to preserving the integrity of the relationship between a caregiver and her patient. Deeply embedded within the principles of medical codes throughout the world and over time is the value of trustworthiness, and in particular, a trustworthy relationship between physician and patient, but also between medicine and society. One of the ways this trustworthy quality is coming into focus in recent years in the U.S. is through telling and listening to stories of patients, family members, and caregivers. Indeed, these testimonies can reveal that our code of medical ethics may not be universally applied, but may need to be inflected and nuanced, given a specific need based on prognosis or religious concern. Thus, this is how the layered and productive relationships of ethics, medicine, and narrative are at the heart of this year's examination of the four pillars of Western medical ethics. With an emphasis on narrative and testimony, the Mudd Center for Ethics program will offer a multidisciplinary inquiry from the fields of anthropology, art, ethics, law, medicine, and religion into poignant questions and dilemmas related to medical research, treatment, and access. As experiences of illness and health are integral to the human condition, we hope this program will offer points of engagement with these complex issues, and we welcome you to join us at any point during this year-long program.
What if someone came with this thing?
Good evening. It is wonderful to see you all. It really is. I'm just taking a moment. I'm very excited for this beginning of a new year. I'll first introduce myself, though, before I go headlong into all of the exciting things. My name is Melissa Karen, and I'm the new director for the Mudd Center of Ethics. And though I stand up here by myself, I assure you, there's a really beautiful team that I stand alongside. Chief among them is Kate Sacchi, who's in the back. She's the senior project coordinator. Our postdoc, Rachel Levitt-Aids, is somewhere here. She is. She's somewhere back there. She's wonderful. She's right there. Yeah, exactly. And then there are 6 wonderful members who make up the Mudd Center Advisory Board. All of us work together and come together at various points to talk through the development of the theme. And I'm sure I speak for all of us when I say I'm really happy you're here with us to launch this first lecture of our new theme for this year, which is, as you can see, how we live and die. It's a theme that relates to medical ethics. Before I go on to frame the year-long program on this topic, I would like to just take a brief moment. It's in the spirit of upholding an ethics of memory that the Mudd Center respectfully acknowledges that we occupy unceded ancestral lands of indigenous nations still governing in and some displaced from the Shenandoah Valley. And this land of Virginia and our own university has been worked and built by a legacy of unfree labor and indentured servitude. So it's now that I feel we can begin to tack a course into the waters of this wonderful theme that we've chosen for this year. I'd like to share with you how we shaped this year and came to decisions about what we would bring forward. We were deliberate in crafting a very interdisciplinary approach that would allow us to explore questions and multiple perspectives addressing human suffering, responsibility, and equity in how we live and die. And the year is comprised of lectures, a panel discussion, and an art exhibition. All of that is very easily found for you here if you have a card, and I hope you do. I hope most of you come away with one of these today. On the front is the slate of speakers for the fall, and on the back is for the winter. And what you're going to notice is that the fall has these really deep lectures that grapple with a lot of issues. And then the back, for the winter term, we get into a more experiential learning process. And that's, for instance, where you will see an art exhibition that I'll talk about in a moment. On this card and right here, you have a QR code, and it's definitely advised for you to tap on that, to go to our website at various points, just to make sure that things haven't changed, right? Logistics can be a little fluid here and there. So place, you want to always be aware that location from now on for October and November will be in Northern Auditorium, not here. So that's one thing to be aware of. Ultimately, what you will notice as well when you look at this and what you will hear from me today is that the program combines what I hope is a very full scope and depth of both humanities and science coming together to grapple with these issues around medical ethics, some of the most pressing that we have today. Realizing that some of you may not know what medical ethics is necessarily, and there's lots of medical ethics. There's lots of codes from centuries ago to the present. What we're working with is something that was developed in the 1970s, and this is what we would call medical ethics in the United States. Autonomy, chief among them, being giving the patient agency to choose freely, beneficence, committing to doing good, non-maleficence, minimizing harm, and justice, ensuring fairness and equity and care and access. During the year, this framework will be examined in light of a triumvirate of dilemmas, ethical dilemmas, that relate to medical research, medical treatment, and medical access. So those three things are what we're going to be grappling a lot with. A central part of the investigations for us will be this idea of testimony and storytelling. And so when you think about medical ethics, you don't necessarily think about storytelling and listening. But for us this year, we wanted to combine the two. This is an example of one of the stories that will be told at the Stainer Gallery, and it's an art exhibition by the artist Erica Lord. So we have, as you can tell, a broad scope all within this idea of medical ethics. But as I mentioned, we wanted to really bring together the humanities and the sciences together in this year-long inquiry. And as we've thought through who in the world can do this, who can really bring these two worlds together, I kept returning to Dr. Adjoa Boateng Evans. She's an assistant professor of anesthesiology at Duke University School of Medicine and a faculty associate at the Trent Center for Bioethics, Humanities, and the History of Medicine. Dr. Boateng Evans received her undergraduate degree at Yale in the history of medicine and also pre-med, again, those two worlds coming together. She went on and did a master's degree in public health at Drexel in Philadelphia. Then she did her MD, at Rutgers. And then after that, she went over to, Rutgers, then Yale. She went back to Yale for her residency in anesthesiology. Then she went over to Stanford, where she did a fellowship in critical care. Critical care. And then she ends up back in the East, over at Duke, which is where she is now. Obviously, she's an incredibly well-trained intensive care physician, but on top of this, she's also a mother, she's a writer, and a TEDx speaker. Through her work, and I will say she's really at the beginning of her already illustrious career, she finds way to bring humanities and sciences together to question things like pain, for instance, emotional and physical, or about empathetic connection in the medical environment, a place that can often be a little too sterile, too distant, too professional. Undergirding and guiding her work in both the operating room and the classroom is her concern with restoring humanism to healthcare. And today, I had wonderful opportunities to see this unfold with our own students. Her lecture, In Critical Condition, A State of the Union on Compassion, Death, and Purpose, takes us into the complex ethical dilemmas that face physicians at the level of critical care. Please join me in welcoming Dr. Boateng Evans.
Throughout the past 15 years, I have run, walked, shocked, compressed, and even prayed as I've injected thousands of ampules of adrenaline into thousands of patients as they died, each time hoping the drug would bring them back from death. And sometimes death happened quickly, shockingly, traumatic, difficult to digest despite carefully crafted, painstakingly evidence-based decision-making armed with the tools of modern medicine to do the work of multiple failing organs. And other times, death was slow, graceful, peaceful even, giving us the opportunity to allow loved ones to gather, combining hearts, eyes, locking hands, so that they could say goodbye as their patient took their last gaspy, irregular breath. This is the life of a critical care anesthesiologist. This is my life, and I have truly felt the blood, sweat, and tears of humanity on my white coat. I've held the hands of children who, in their very rational, very practical, very present, but oftentimes naive reality as they color pictures and write letters to mommy or daddy whose body has been consumed by cancer, marred with the toxicities, and ravaged by chemotherapy and radiation. I've received countless phone calls from family members asking, how is my loved one doing? And as I share the disastrous news, they choke through their words. My only consolation is that their loved one won't die alone. In my personal life, I have received many phone calls from my own friends and family about how to die. Is this the end? Do we pull the plug? What would you do if this was your loved one? And more importantly, what do we do next? Where do we go from here? And so this afternoon, I want us to explore the complex ethics around death and dying in the United States. And specifically through this narrative medicine style talk, I want the stories shared to really serve as a springboard to think intently about how you or the ones you love would want to spend your final days. Because if there is one thing that is certain, it is that we are all mortal. And while there's no established or correct way to die, we all have the ability to be thoughtful and intentional about death in the same way that we are thoughtful and intentional about the rest of our lives. And so to begin, let's think about how did we get here? Let's think about how we die, specifically the role that autonomy plays in this divergence between how most people want to die and yet how most people actually die. And so here, you actually see a shift over the past few decades whereby less patients are dying at hospitals and more are dying at home. And this is due to sort of a complex interplay between patient preference, expanded coverage by Medicare and Medicaid services for end-of-life care, and this perception, this narrative that a good death, quote unquote, is one that occurs at home, surrounded by loved ones, that is ingrained in sort of our social and cultural history. But yet sometimes, and I've been bear witness to this, the best laid plans for a good death at home with family and friends unravel very quickly. Also in this discussion is the role of language. In fact, most individuals do not differentiate between death and dying and use the terms interchangeably. And as Melissa was mentioning, although I'm a doctor, I'm a physician, I'm also a historian at heart. So I'd be remiss if I didn't give a brief primer on the history of dying in the United States. And so what we know is that in the 19th and 20th century, most deaths occurred suddenly without warning due to short-term infectious diseases. These deaths did not discriminate, right? So you have infants, children, mothers during childbirth dying instantly. What we see now is death, and what we see now is dying. Dying in the contemporary United States is generally, but not always, occurring to an elderly individual following a long-term chronic illness. To give some numbers, about 3/4 of deaths occur to individuals age 65 and older, many times in an institution, sometimes at home, and frequently with the use of life-extending medical technologies. Most importantly, man-made diseases, or what we call lifestyle diseases like diabetes and heart disease, have largely replaced infectious diseases for the cause of death. And on average, patients make 29 visits to their doctor's office in the last 6 months of life, and about 20 to 25% of patients will die with intensive care services. And yet most patients, when you ask them outside of the ICU, indicate a preference against these life-extending technologies. And so historically, death, like birth, was a family, communal, or even a religious event, not a medical one. Dying is protracted, sometimes anticipated. Death is sudden, unexpected, and tragedy, I would say, actually lies between the two. My work in the intensive care unit dwells in all three of these spaces. And so now, with these technologies, because death can essentially be postponed, if you will, the questions and ethics surrounding these life-extending technologies are many, and they're very complex. And even as I stand before you today, right, my speech is littered with the term death and dying, and that might make some of you uncomfortable. And that's because we're not engineered in this country to face our mortality, aside from it being one of the most certain aspects of life. All individuals will die, and thereby, if we have loved ones, many of us will become bereaved, and almost all of us will experience grief of some sort at some point. When my colleagues and I sit together with families to break the news that their loved one will not survive their critical illness and that they are dying, we have to be very specific in the words that we use. In our critical care training, we know that there are various aspects of these difficult decisions that are of the utmost importance. And so we prepare a quiet space without distraction. We introduce ourselves and our roles in their loved one's care. We do not use jargon. We actually welcome uncomfortable silence. We read facial expressions even behind a mask. We listen to what is spoken, but more importantly, we listen to what is unspoken. And we do not use euphemisms such as, your loved one might not make it, or things are not looking good. We specifically use the words death and or dying. And this is built into the way that we communicate with one another in our sphere of critical care, which is very distinct from messaging outside of the ICU. And there are many reasons why we have such difficulty conceptualizing, facing, digesting death in this country. I mean, one can travel to your local pharmacy and see countless anti-aging products and things to restore your external vitality and external youth. But truly, on the inside, there is not much that you can do to reverse that aging process. And so one of the reasons why we have such difficulty stems from differences in the way that we value life. And so this is where the notion of autonomy comes in. What controls does one have over their trajectory if he or she is dying? The image and headlines you see before you chronicle the 2017 case of a 70-year-old man who presented to Jackson Memorial Hospital, which is a large level 1 trauma center in Miami, Florida, in distress. He was unconscious, he had a very high blood alcohol level, and his body was in septic shock, that is, fighting an infection that it was unable to overcome. Importantly, as you see here, he had the words, "Do not resuscitate," tattooed across his chest, even accompanied by a signature. And despite as clear as this messaging might seem, it actually created quite the ethical dilemma for the emergency room and critical care physicians taking care of the patient. This action created more confusion than the clarity that was intended by the permanent markings. And specifically, the questions raised were, was this legally sound? Was this accurately portraying what the patient wanted, and should it be honored? The patient arrived with no identification, no next of kin to speak on his behalf. And so the doctors actually did not immediately implement the DNR, or do not resuscitate, order. They gave him intravenous fluids, they gave him intravenous antibiotics, they gave him medication to artificially support his blood pressure. But as his pulmonary status and his breathing deteriorated, they really grappled with the idea of, do we intubate? That means place a breathing tube down into the windpipe and put him on a ventilator, which by definition is resuscitation, which by definition is opposite a do not resuscitate, and which by definition is life support. And so they wondered if this tattoo was actually in jest, which mirrors an ethics case about 5 years prior to this one, where a gentleman actually lost a bet, tattooed "do not resuscitate" across his chest, but did not actually mean it. And so, struggling to understand what exactly this meant, they consulted the social workers who said, in the state of Florida, to complicate matters further, in the state of Florida, DNR orders are to be printed and signed by a physician on physical, tangible paper. Needless to say, the patient did not arrive with this, and most patients do not. So, feeling stuck in these very murky waters, the doctors did what many of myself and our colleagues would do, is they called you all. They called the ethics team. And the ethics team actually deemed the tattoo a reasonable expression of the patient's preferences. Specifically, they said, the law is sometimes not nimble enough to support patient-centered care and respect for patients' best interests. And the social worker did obtain his DNR paperwork from the assisted living facility, and the patient did die the next morning. But what this case tells us is that if one feels so strongly in his beliefs to go against the train that is the US healthcare system, that he has to physically tattoo "do not resuscitate" across his chest, what does that mean for autonomy as we balance life and death? Physically tattooing a living will on their arm or on their face to prevent us, the proverbial us, from doing things that one does not desire to maintain autonomy. If this is the case, then truly we need a better system to manage patients' desires at the end of life. But to be fair, not every patient feels this way, and in fact, our numbers would suggest otherwise. As I described, most patients die with the use of medical intensive services, but what this also tells us is that patients have the autonomy to say no to life support, but they also don't always have the ability to say yes. Even a century ago, physician poet Oliver Wendell Holmes wrote of the United States, "How could a people which has a revolution many in 4 years, which has contrived the Bowie knife and the revolver, be content with any but heroic practice?" And interestingly, now that this is the 21st century, this phrasing is actually analogous to the language that my colleagues and I use to describe patient desires. And so when communicating with a colleague, I might say, the family in room 12, they want heroic measures. That means they want everything done. They are a please resuscitate, not a do not resuscitate. And we have certainly seen what persons of faith describe as miracles in the ICU, individuals who by our medical predictions and prognosis survive the unfathomable in ways that we cannot explain scientifically. And this intersection of science and spirituality is at its pinnacle when one is facing death. A few years back, during the peak of the COVID-19 pandemic, where I was simultaneously growing life, I was pregnant with my first child, my son, but also working in the ICU, watching so many lives transition to death, I wrote this poem to reconcile my two worlds. On the one hand, I was ecstatic and going to obstetric appointments, and on the other hand, I would leave my obstetric appointment, go into the hospital, and be met by our chaplain saying, "Please sign this death certificate, Dr. Boateng Evans." And so feeling joy about this burgeoning life in my wound, and yet grief for the many, many patients and families with whom I walked beside for the death and dying process, I had to figure out a way to articulate the thoughts that my normal communication could not, and so I wrote this piece called An Ode to the Ill. The wails of the dead still hum hymns. Nestled in the fabric of ICU rooms lives the echo of lives lost. Walls decorated with voltage to assuage our everlasting fear of a heart that says, no more. Syringes plump with adrenaline to jolt you to consciousness when your body says enough, and machinery to salvage your breathlessness when words can't make their escape through your frozen wind. I give you my all, emptying my own vault, my own growing life to keep yours. Sleep, water, food, time, gone. Sacrificing my own rest to ensure yours is circadian. Forgoing my own nourishment to feed your spirit, praying, hoping, wishing that the walls of the dead did not join us here today. Breath stolen, time taken, soul saved, empty vaults of gone voices, honor we give back to you. The image you see here is the pinnacle of life support. This is how the great majority of my patients in the intensive care unit appear. You walk into the room and you are met by a cacophony of machines doing the work of multiple failing organs as patients battle for their life. And as you can imagine, there is not an infinite availability for these mechanisms of life support. There are times, most pronounced during the COVID-19 pandemic, where we actually have to consider resource allocation. And this can certainly violate autonomy, right? We have to decide who gets a chance to extend their lives. And so ECMO, as you see, where's the ECMO machine? Kind of here, stands for extracorporeal membrane oxygenation, or in colloquial terms, it's the heart-lung machine. ECMO is sort of the most extreme or highest level of support modern medicine has to offer. It does the work of the heart and can sometimes do the work of both the heart and the lungs. And so because of this kind of finite resource, many centers have developed criteria to be thoughtful in the provision of this very extraordinary undertaking. In broad strokes, ECMO is used for 3 indications. As a bridge to recovery, so if a patient has heart surgery or has significant heart failure, we cannulate them onto ECMO to give their body time to heal itself. As a bridge to what we call destination, that might mean a bridge to transplantation, like a heart transplant or a lung transplant, and the machine does the work of the failing heart and lungs until they can get to that destination. Or as support, and sometimes we actually have to crash patients onto ECMO to do another life-saving procedure. The cost of ECMO ranges from about $20,000 to $40,000 per day. And patients can stay on ECMO. It's not uncommon for patients to stay on ECMO for weeks at a time. And so due to this complexity, due to this cost, there are unique ethical considerations for this particular form of life support as compared to others. So in medicine, informed consent has risen as a way to sort of balance, autonomy that we've been talking about, beneficence, and also non-maleficence. The idea being that if I present to you the risks and benefits of undertaking this high-stakes intervention, we, under shared decision-making, are going along this with all of the appropriate considerations in mind. The challenge is that when we deploy ECMO, we're often doing so in urgent and or emergent situations where we don't always have the luxury of discussing risk and benefits with patients. And because many healthcare centers have developed criteria to decide who should and shouldn't get cannulated into ECMO, as you can imagine, the waters can become very gray. And so here you see some of the ECMO criteria and considerations. On the left of your screen, some much more medical, but on the right of your screen, these are patient demographic factors, right? And so certainly these categorizations are not universal. This is just one specific center, but it is representative of kind of what is expected among inclusion and exclusion criteria in hospitals that offer ECMO. So, does this mean that a patient who is over 55 or has a BMI that is over 40 kilograms per meter squared, do we value that person less because we do not offer them a chance at this life-extending therapy? Not necessarily. And so because of that, I'd like to play you a story of a gentleman who had severe, sort of intractable lung disease called COPD, or chronic obstructive pulmonary disease, a chronic condition for which there is no way to sort of reverse that pathology, whose life was saved by this extraordinary technology. The alternative would have been weeks, probably months, maybe waiting for 12 tracheostomies.
So listen, we're in no rush.
We're going to know in like 1 second.
You set the pace. Okay, off we go. Guys, we're going to turn to the right.
This is unique. This is truly amazing. We have great doctors and the nursing staff and the physical therapy. It truly takes a large team to support that.
How you feeling? Yeah? How's your breathing?
Okay.
Yeah? Are you winded? No.
I think we're really at the cutting edge of what we're doing with the ECMO device and really moving away from what we're doing with the ventilator. I think we've realized now in medicine the dangers of being on the ventilator, the dangers of being in a hospital bed, not getting up. So I think these devices hopefully will push us in a new direction with patients with this type of breathing problem.
I'm feeling good now. Thanks to the life-saving device that they have here, I'm still alive, So I'm grateful to Presbyterian Hospital, for giving me another chance. If they can do that for me, I can do this for them. Take care of my health, take my medications, and hopefully I'll see you again and, they'll see me looking even better.
unfortunately, every patient on ECMO does not have this beautiful outcome. The complications are many, and sometimes the complications of the circuit alone can be fatal. Massive hemorrhage, neurologic injury. In this case, and in many of the cases where we choose to cannulate patients onto ECMO, there is a multidisciplinary team who decides to make the intervention on essentially an educated bet that a patient like Ivan would get better, he would recover, he would come off of this life-saving technology. And we do this for humanity, right? To bring someone like Ivan back to an acceptable quality of life with the people who mean the most to him. However, despite all of the best prognostication, the storybook ending you've just seen is not always the case. And if one is sick enough to need ECMO, that means that the alternative is usually death. And so when the alternative to an intervention is death, that definitely alters the usual ethical consideration. And if there is one international event that illustrates this level of kind of complex decision-making and also brought together my worlds of anesthesiology, the ethical considerations around life and death, and the use of language, it was the Thai cave rescue effort in 2018 where 12 young boys, ages 11 to 16, and their 25-year-old soccer coach went exploring and became trapped deep inside a flooded cave underneath a mountain in Thailand. And so one can conceptualize the ethics here under the umbrella of sort of disaster management, where the foci are resource allocation and saving the greatest number of lives using a sort of utilitarian ethical modeling. However, this was actually quite unique because despite this being a disaster, there's actually an abundance of resource outside of the cave, away from the boys who did not have food, who did not have water, and were living in a sub-atmospheric oxygenation level in the cave. Additionally, although the young men did not have these, it became very clear early on that they would essentially have to be unconscious to be saved throughout the cave. And throughout this tortuous long cave and the time constraints, it became clear early on that there was no role and there was no time for sort of informed consent discussing risks and benefits. In fact, one of the coaches, a former monk, he taught the young boys to meditate, to help them stay calm and use as little air as possible and to conserve their strength. And so the options here were essentially die a slow death, try to retrieve them, and once reaching, realizing that we don't think that we can get them out after failed attempts, die a potential faster death, which is we try to save the boys and they might die on their way coming out of the cave, or what seemed nearly impossible, which was success, life. Ultimately, the rescue required that the boys be dived out of the cave while fully anesthetized. And to be clear, this is not sedation, that you get when you have a minor external procedure. This was under full general anesthesiology. And in this moment, to do this underground in a flooded cave meant that the risks were extreme. Beneficence as a guiding principle here becomes a very major challenge when all the rescue options appear destined to cause fatalities. So I can cause death if I don't do anything. I can also cause death if I try to do something. While anesthetized, the boys would have had unprotected, unmonitored, out of sight, and totally inaccessible airways for a significant amount of time, as you can see here, and they were underwater. This is not only the antithesis of how we operate as anesthesiologists, it also breaks many of the fundamental rules and ethics around the administration of anesthetic medications. And more practically, it would cause immense anxiety for any practicing anesthesiologist to even think about this responsibility, because any small ingress of water into the mask, and certainly if their masks had become dislodged, would cause asphyxiation and death of these otherwise healthy young boys. And so considerations were plenty, time was ticking, and a multidisciplinary team came together. My question, though, before we get on to the logistics of this, for anyone who is familiar with this case, and I'll be very impressed, you'll get a gold star from me, who can tell me what anesthetic agent was used to anesthetize the young boys in this rescue mission? Anybody know? Someone knows. Someone has seen the Netflix special. Really, no one knows? Guess, just guess. Oh, you didn't watch it. Ketamine. So ketamine is a very well-designed drug. It causes amnesia. It causes a bit of anesthesia, but it allows you to sort of breathe spontaneously for a period of time. And so ultimately it was virtue ethics, the traits of characters of the rescuers, that enabled this very difficult decision to be made in the rescue to proceed. So things like compassion, thoughtfulness, trustworthiness, honesty, integrity, and benevolence. But simple adherence to these principles is actually not adequate to deal with the complexity of the moral and ethical problems encountered in normal practice, and this is especially true when faced with sort of emergency or disaster situations. And so a group of about a dozen international cave divers were this example of a very highly functioning team. They came together with short notice, literally from all over the world, the United Kingdom, Canada, Finland, Denmark, Australia, led by an anesthesiologist. Some of them were meeting each other for the first time, and together in the space of a few days, they not only planned out, but executed a complex and dangerous rescue, and did so under immense pressure. Dr. Richard Harris, describes the rescue efforts here.
On the day I left to go to Thailand, I was in the operating theatre, and I had a call from Rick Stanton, the British lead diver, and he asked if I could come over and consider sedating the children to get them out of the cave. I was pretty horrified at that idea, to be honest, and I didn't think it was possible, but I did agree to come over and give them a hand. And Rick said to me, and something that has really made me stop and think, that he said, you know, Harry, if you come over, it's likely that you're going to swim to the end of the cave, you're going to look at these kids and see their beautiful smiling faces, and then probably you're going to swim away and leave them to die. So it was pretty sobering to hear that from Rick, and it actually made me second guess myself and wonder whether I really should be going over. The next day we were diving in the cave. We saw these kids with their own eyes, and I can't tell you how amazing they were, how resilient they looked, how much they were still smiling and walking around. For a completely disparate group of international people to come together with the goal of saving the lives of 12 children and their coach, who they'd never met before, didn't know anything about, that tells me that the spirit of humanity is really still alive out there, and we just have to navigate our way through all the badness and find the good stuff that's still there in mankind.
And what he says here is, it's so beautifully stated, so poignant, and so succinctly encapsulate what speaks to all of us, which is this shared humanity. And I encourage you to watch the film if this spirit of kind of science and humanity resonate with you. But what this event also highlights is the notion of justice, right? So who determines if we die? Who determines how we die? And would these efforts have been different if these were 12 elderly men or 12 criminals? And so I want to explore the notion further through inequity in dying patients as a lens to think about justice or injustice at the end of life. If you pick a demographic, insurance status, race, education, you will find stark differences at the end of life along these factors. For the students in the group, we call these social determinants of health. At the end of life, because these can greatly influence how one dies, we have some scholars have kind of flipped this term and actually call them social determinants of comfort. The idea being that the less sort of challenging your lifestyle is, the more likely you are to die in a comfortable way. But this is also a reflection on the differences in how we value life. Ethnic and racial minority patients are much more likely to be hospitalized and receive aggressive care during their last 6 months of life. And so by virtue of this, much more likely to die in a hospital. And during this time, ethnic and racial minority patients are also less likely to have access to things like palliative care, the use of hospice, and to be less satisfied with the quality of care that their loved ones receive, frequently citing concerns around communication. The why behind this is multifactorial, and I think historically a lot of scholars would say, well, it's due to distrust of the medical system, but we know that that is an oversimplified and actually antiquated rationale for a more complex explanation. One reason is this concept of reckoning, and I've seen this play out, where patients sort of feel like you, the healthcare system, have denied me access to proper healthcare services, some which may have contributed to my demise. You've dismissed my concerns. You have not fully let me in. And so now at this final hour, I want everything done, and you will not deny me access to that. But there's a sort of disenfranchisement that comes with that, because in many and if not quite frequently, a lot of these instances, we do things to extend the quantity of life without extending the quality of life. Additionally, hospice and palliative care medicine were sort of erected to support patients with cancer. However, racial and ethnic minorities often suffer from more chronic lifestyle diseases, if you will, such as end-stage kidney disease or heart disease, which can produce actually similar symptoms to cancer patients, but are not seen to need things like hospice and palliative care support. The other less tangible are these differences in communication, and something I have also observed quite a bit in my own work in the ICU. And this is a great reason as to why these disparities persist and why we need to diversify the healthcare workforce. This is a paper by Dr. Amber Bernardo, who was based at the University of Pittsburgh at the time of publication. It was published in 2016 and sort of ahead of its time in some regard, because what this paper highlights is what we now know as unconscious bias, which is kind of the fodder, the groundwork for structural racism. And here, the authors conducted a randomized trial to evaluate the relationship between patient race, embodied by the skin color of a patient, and physician decision-making. 33 faculty completed encounters with two prognostically similar, critically and terminally ill patients, one Black, one white, with identical treatment preferences, each accompanied by a family member. The researchers told the faculty that they were studying how hospital physicians make decisions for sick patients who they do not know. The encounters were recorded from an audio and video recorder and used a validated tool giving 1 point or 0 points for the presence or absence of positive communication behavior. And while no difference was found in sort of verbal communication between Black and white patients, there was a significant difference with higher nonverbal communication scores with white as compared to Black patients that was statistically significant. And so behaviors such as open body language, eye contact, proximity to the patient, touch, that really underlie the patient-doctor relationship and help to build rapport were unavailable to Black patients. And so these entities such as attention, warmth, availability, empathy were frequently much less common as reported by minority patients. And it's been speculated that a physician's inability to recognize minority patients' nonverbal cues and the physician's disengaged nonverbal communication with working with minority patients is what creates greater patient dissatisfaction, worse patient compliance, and certainly contributes to racial disparities and health outcomes at the end of life. But what is most concerning is that our research in this area demonstrates that these inequities manifest in adverse experience such as more pain, greater financial distress, greater caregiver burden, particularly for women, and worse reported experiences with death. And so naturally that leads us to the crux of our conversation, which is, what does it mean to die a good death? What is a good death? And so when we think about a good death, we sort of conjure up images on the left of your screen of an individual dying at home after a life well lived, surrounded by loved ones with candles and soft music playing in the background. And we have wonderful teams of social workers and case managers and hospice agencies to sort of help set up things like this. But the reality is that I've heard from countless family members, caregivers, that they were not physically or emotionally prepared to care for the severity of things like pain medicine, agitated delirium, incontinence, cleaning that is also required to facilitate someone transitioning from life to death. And so what sounds very idyllic can very quickly become overwhelming and scary. And what happens is caregivers then do what they know best, which is bring their loved one back to the hospital. And there, we land in a space where there's a gap between how we want to die and then oftentimes how patients actually die. And with unclear patient desires and this push in medicine toward beneficence, right? We all take a Hippocratic oath in medicine saying, I will do no harm, and non-maleficence, I will not hurt you. It truly creates a very complex social factor that can, in many instances, perpetuate health inequity. And so while the answer to this question, what is a good death, is very heterogeneous, what is relatively unified in our research in this area is the central role of autonomy, that those who are dying and their families actually have a say about the site, the type, and the duration of care one receives at the end of life. The challenge is that many patients, many dying individuals have not made their wishes known. And so that makes the difficult decision left to family members, to friends, where we say, if your loved one were sitting here in the room with us, what would he or she want? And we're often met with blank stares or, I don't know. And without clear decision making, our default in the United States healthcare system, as I painted for you today, is to do everything. More testing, more surgeries, more invasive procedures, more poking, more prodding. And many times this results in financial, emotional, and physical drain without the intended outcome. And again, as physicians who have taken this Hippocratic oath to do no harm, we were historically guided much by this nexus of beneficence and non-maleficence, then autonomy. But now we have things like informed decision-making, informed consent, shared decision-making, and in certain states, physician-assisted suicide. And so here you can see the variability by state on where one actually has the right to die. That is legal medical aid in dying. But it's clear that where a patient and family live, this social determinant of health will either facilitate or hinder implementation of this type of care plan. And so these can range from not only the built environment, like city landscapes and architecture and the quality of air that you breathe in. Do you live in a food desert? Access to education. Do you have sidewalks? Are you able to get jobs and have social supports? But also, can you travel? These multiple complicated factors contribute to what measures are available, what's offered, and what's accepted by patients and their family. And really, at the heart of this, the key drivers are really reimbursement, provider knowledge, culture, and geography. And the fact that there is such wide variations in something like medical, legal, assisted dying speak to a significant social injustice at the end of life. And so I'd like to build off of this notion of communication within end-of-life inequity and talk about tools to alleviate the injustice. I mean, I think it's one thing to describe a problem, but the next step should be, how do we fix the problem? And something that we all have the ability to do is be mindful of our language. I do a lot of breaking bad news and saying things like, unfortunately, your loved one is in critical condition due to X, and we're worried that they will die. And I'm often met with the phrase, well, my uncle is a fighter. And the challenge with this language is that a fight indicates that there's winners and losers, and also that not fighting is giving up. And so I respond with things like, your uncle is a fighter. He's fighting right now, but his body is showing us the limits of what he can withstand. And just to convey that the body has natural limits, and in doing so, we sort of absolve patients and families of this fault, this guilt, that if the outcome isn't more life, and the other corollary to this fighter terminology, an obligation to keep trying, that's okay. And that we in medicine are really good, again, at offering sort of more and more, but these can be wrought with more risk, more toxicity, more deleterious outcomes. And so I think reframing the conversation can be helpful, not only to patients and providers, but to this larger kind of conversation about the legalities and ethics at the end of life. So saying all this to say that I think that sometimes we can bridge the gaps of injustice with the mighty tool of language. And I'm making these points about language because beyond medicine, a lot of us face dilemmas which feel very binary, very black or white, very right or wrong. And we're certainly bred this way in medicine. And I, as a young doctor, inherited this schema, but the more that you grow in your field of study, your area of inquiry, and for me, in my career in medicine, you find that there's science, but medicine is actually in many ways more so an art. And you find that living in these very kind of nebulous gray areas is where there is not necessarily a true right or wrong, can give you the exact answer that you're seeking. And so one of my favorite questions to ask families to move them from talking about machines and procedures is, tell me about your loved one before they got sick. And I met with laughter, sometimes I met with smiles. They were spicy, they were fiery, they loved to play golf. People show me videos and pictures. And it's so helpful because those videos and pictures look markedly different than what I'm seeing in room 9. But it is those very moments, right, where I can bridge what I'm seeing with what used to be that bring out the value system and really capture the humility, the honor that many of us approach these very tenuous final moments. This is what brings humanity to healthcare. And so as I conclude, I think what we've gotten wrong about the end of life is conflating death with suffering. Dying does not always have to equate to suffering. In fact, there's an entire medical specialty with whom I work very closely, as I mentioned today, whose goal it is to alleviate pain and suffering at the end of life. And people have angst about their mortality for a variety of reasons, but I think chief among them is pain, right? And sometimes pain is inevitable. Suffering, I think, for all of us has started to infiltrate whatever confined space or box we relegated that emotion, and sometimes it can feel unavoidable. So how do we palliate? How do we temper with what feels like burgeoning, growing, insurmountable crescendo of pain? And I think the younger me, the younger Dr. Boateng Evans would say, well, find joy. But having seen so many tragedies, so much death, so much despair, it's not joy per se, because I think we can conflate joy with happiness or pleasure, but rather my challenge to you is to find meaning, find purpose, find compassion, because during those difficult days, this is how we unearth the humanity in one another and rediscover kind of what I've painted for you today. This is how we save lives. Storytelling, narrative medicine, which I've used, is an extraordinary tool that really crosses the boundaries of various disciplines, and it's at the heart of how we communicate. In healthcare, storytelling is our bloodline, and we tell stories every day, formally in a very sort of language that is ingrained into our brains from the first day of medical school, but also in informal decompression moments. If someone ran in here today and said, Dr. Boateng, 55-year-old, positive fast, hemoglobin 4, you would see me run out and tend to that individual urgently over those 8 words. And so for physicians and for all of us, I think it is the storytelling that is slowly beginning to heal all of us, and particularly heal the healers. And so as I wrap up, I want to acknowledge that I've discussed a lot of heavy material today, and I've put a lot of that into the ether. And so I'd like to end with some inspiration by reading a poem by poet laureate Amanda Gorman, who wrote A Hymn for the Hurting in 2022 after the Uvalde massacre. She wrote, "Everything hurts, our hearts shadowed and strange, minds made muddied and mute. We carry tragedy terrifying and true, and yet none of it is new. We knew it as home, as horror, as heritage. Even our children cannot be children, cannot be. Everything hurts. It's a hard time to be alive, and even harder to stay that way. We're burdened to live out these days while at the same time blessed to outlive them. The alarm is how we know we must be altered, that we must differ or die, we must triumph or try. Thus, while hate cannot be terminated, it can be transformed into a love that lets us in. Let us not just grieve, but give. May we not just ache, but act. May our sign right to bear arms never blind us from the sight from shared harm. May we choose our children over chaos. May another innocent never be lost. Maybe everything hurts, our hearts shadowed and strange, but only when everything hurts, may everything change." And finally, I like to end my talks by asking, what is your why? And many people ask me, why have you decided to go into critical care medicine? Why do you want to deal with people who are dying all the time? And I would say this is my why, right? My faith, my family, connecting with souls and minds and inspiring individuals like all of you. And that's a separate lecture, you know, sort of what is your why? But these are the times in which I really see humanity, connecting with new individuals. And so I really want to thank you all for extending this invitation to join you today, for your immense hospitality, for Melissa, for Kate, for Rachel, the students for your insightfulness, your thoughtful questions, your poise, your grace, and really your dedication towards change. Truly, I thank you. Wonderful.
Hospice physician. Let's go back to Ivan for a second. What was
The gentleman who was cannulated onto ECMO? I don't know the answer to that, if I'm completely honest.
Should we have had a palliative care or hospice discussion with him after that event and continuing on? And this sort of goes to the central point that I think we have a great failure in our system that we don't address quality of life, acceptable quality of life before we go into the ICU, and we also don't do that in the survivors who leave us.
Yeah, that's a great point. I will say, so I've worked at sort of 3 major teaching hospitals now, Yale, Stanford, and Duke. And things are different in each place, as you can imagine. In one of those places at Stanford, they actually do exactly that. So when you order, all the orders for ECMO, which there are many, from the heparin drip to the perfusionist, et cetera, it actually defaults to a consult for palliative care. Because of exactly what you described. I mean, this is an immense undertaking, and many times there's no guarantee that they will come off. I mean, he looked pretty good, right? He was ambulating, he was talking, presumably he was eating and able to get back to a relatively great quality of life. But I do think that as a medical society, and that's why I emphasize language so much, is that we use these euphemisms, or we're scared to break bad news, and in doing so, we just do a disservice to folks because they're not getting the information that can actually help them make a decision that is in line with their value system. There is a piece that I sort of grappled with including, but I didn't want it to be too graphic for you all, about code status. So for those of you outside of medicine, when you're an intern, you start medical school, the senior resident or the attending will say, did you go in that room and ask the patient about code status? Like, what does that mean? So that means you're asking this patient and their family, if the patient dies, quote unquote, what do they want done? So the intern walks into the room and says, if your heart, if your heart would have stopped, do you want everything done? And most patients who are asked that will say, yes, please revive me. But that is inaccurate, and we're doing them a disservice. What we really should be saying is, listen, if your heart were to stop and you were to die and suffer a cardiac arrest, which is mildly likely, moderately likely, highly likely, do you want us to rush in here, thrust on your chest, crack your ribs, cause bleeding, shove a tube down your throat, put you on life support, on the risk that maybe you would survive this, although you probably might not leave the hospital? Would you want that? Very different language. But that's a scary conversation. It makes people uncomfortable, and no one likes to be uncomfortable. So that's where we are.
Any other questions?
Yes, please.
In your opinion, that right to die legislation should be universal? I was kind of struck by how few states allow it.
Yeah. I think so. And the rationale for that is that it kind of gets back to what your colleague was mentioning, is that even if everyone does not opt for right to die, because it exists. I mean, I lived in California, and it wasn't like every patient was undergoing physician-assisted suicide. I think I saw 2 patients over 4 years who use that. So it's certainly not ubiquitous. But what it does do is sort of normalize these conversations about end of life, which we all avoid, even in the best of circumstances. What it does do is bring about this conversation about value systems. And so I don't know necessarily that it being universal would change the rates of utilization, but I do think it would certainly change the culture around how we approach the end of life. Definitely.
Yeah, one more. I'm so very two more questions. This young lady here.
I was curious if you had any thoughts on why the decline in hospital deaths is and why there's a trend towards hospice. Do you think that's because people have more choice and more awareness of these options, or is there a cultural shift in how people want to die?
It's all of the above, right? So even just expansion of Medicare and Medicaid reimbursement for end-of-life services for patients to go home on hospice and for their insurance to pay for hospice care, that's new. That was not always the case. These were not things that were sort of valued by CMS, by the Center for Medicare and Medicaid Services. And so that alone, that logistical kind of obstacle, dissolved, and so more people have access. But I think also, like I said, this move from feeling like medicine is this paternalistic effort to do things that I don't want, and folks wanting to kind of have this good death at home where they're not, stuck with wires and tubes and getting things done that they don't desire. And I think that certainly when and if it's appropriate, we really do try to get patients back home so that they can have the death that they want. And so I think certainly part of it is logistics, pay, reimbursement, but part of it is this social, cultural narrative that dying in a hospital should not be, where one has their final moments. It feels cold, it feels sterile, it feels impersonal. It has nothing to do with how this person has spent however many years of their life. They have no personal relationship with that hospital, So I think that's part of it. Yes.
So
sorry.
So what you mentioned earlier with when the interns go and they ask the families, like, do you want to be resuscitated if your heart starts beating? The way you described, you said it should. It was like, honestly, I feel like that's a very scary way to go about it. And while you're telling it to the patient straight, and it's the reality of what it is there like a balance between telling it to the patient straight and then also almost like scaring them with the reality of it?
There really is. And again, that's why I emphasize language and emphasize this idea that medicine is a science, but it's also an art. And I was sort of saying that a little bit in jest. That, if someone comes in for a toe injury, we don't necessarily have to go into the throes of doing CPR on them. And so there certainly is. But I think kind of personalizing that discussion to the patient and not having this blanket approach that says, if you die, do you want us to bring you back? I mean, I've seen people ask that, and that is unfair and inaccurate to ask someone because the reflex response by most patients would say, yes, I want to live, But, what is nuanced is that if someone does have a cardiac arrest, what is the likelihood of survival? What is the likelihood that they will leave the hospital? What is the likelihood that they will return to an acceptable quality of life? If they do all of those things, survive the cardiac arrest, leave the ICU, leave the hospital, how much time would they even have after overcoming all of those obstacles? And, prognostication is one of the most difficult things we do in medicine, but I think if you can at least kind of paint some bounds around that, it's very helpful. So in my conversations, common question I get from families about their loved one about patient is, how long do we have? How long do I have? And, we get that question wrong a lot. But what is helpful is giving frames. So I'll say, I think we have minutes to hours, hours to days, days to weeks, weeks to months, right? That's at least gives some sort of objectivity to something that feels otherwise kind of gray, nebulous, and unclear. We have more time for questions? Okay. I think there's in the orange shirt back there.
Yes. In a society where death and dying is avoided at all costs, how do we as a younger generation kind of bring up that conversation with our families so that this isn't like a panic? What do we do when we get to the hospital?
Yeah, great question. I'm really glad that you asked that. I think normalize it, right? So if there is some time where, unfortunately, you are dealing with maybe another loved one who is suffering a serious illness or a terminal illness, that's a great time to just start with the people that are important to you, whether that's your parents, your grandparents, your aunts or uncles, your siblings. Like, hey, I see that our neighbor, John Doe, is diagnosed with lung cancer. That's really sad, and that makes me feel these things. Mom, Dad, if that were you and you're at the end of your life and they said that there's nothing else that we could do, how do you think you would want to die? And they'll be caught aback by that, right? No one, they're going to be like, I'm not dying. I've asked this question to my parents. They're like, what, are you trying to kill me off? I'm not dying. And I'm like, listen, I'm an ICU doctor. It's not even really about you. It's like, we got to understand your values here. But you have to start these conversations because, quite frankly, even in the ICU, it's not even one. I mean, we have multiple meetings with families. I'm talking about like 2, 3, sometimes 4 meetings with one patient and their family to help decide these things. So you can imagine that it would be quite challenging outside of something that feels imminent and critical.
I was just going to say in response to her question, our local hospice organization has a booklet called 5 Wishes.
That's
and
wonderful.
it takes the legal paperwork and it frames it as what you want. And actually, if it's signed and witnessed, it serves at the same as the advance directive in the state of Virginia. So it's a way of approaching with family members that's a little bit less legalistic.
And caustic, probably, then. How do you want to die? But yeah, I've seen the 5 wishes. In California, they use that. You know, again, unfortunately, state by state, there's a lot of differences. In North Carolina, I've not seen that as yet, but that's a very useful document. I don't know if everyone could hear, but it's called 5 Wishes. It really encapsulates the value system that one would want, despite having to ask like very technical or legal or like machine-based interventions. Just kind of how would you want? So, for example, you know, when I have this conversation with a loved one of mine. She says, if I cannot talk, if I cannot eat, if I cannot walk, and if I'm unaware of my surroundings, just let me go, right? So that is not, you know, do you want us to do CPR or not? But it kind of couches what the value system is there, right? And that's a common sentiment amongst folks. However, there are individuals who say, as long as I have a heartbeat, keep me alive forever. There's no right or wrong, right? This is just what people feel about their life. Mm-hmm. Thank you.
It's really wonderful to hear all of these questions and thoughts and responses. The interest is deep. And so please remember there's another talk in October 22nd, and another in November. I will just mention that in February we will have a panel discussion, a good 2 hours discussion about this issue around ethics of medical aid and dying aid, which brings in law and a number of other issues, as you might imagine. So there's still a lot for us to delve into. This is an incredible start, and I'm so grateful for what you shared with us. And thank you all for listening.
Thank you all.